I'm Rich Pandey and Mike Gibson coming to you live from AHA 2025. I've always thought food is medicine, and I was so excited to see your work about the food heart failure trial. Talk to us little bit about the background, why you did it, and what you found.
Yeah, thanks, Mike. And you're absolutely right. And I think food is better than medicine in many ways, and it can actually prevent the need for being on many medicines. So we have always been interested in food as like healthcare by food interventions and food as a strategy to complement our current management approaches for heart failure patients. And we take care of patients with heart failure in a county hospital quite a bit who have a lot of food insecurity and don't have access to healthy food like DASH diets or low sodium diet when they go home from their after heart failure hospitalization. So our study, Food HF, was a randomized control trial that evaluated two hypotheses. First was whether food supplementation compared to usual care can improve clinical outcomes and quality of life in patients after heart failure hospitalization. And this was funded by the American Heart Association Food as Medicine Initiative, and
Hmm.
we're grateful for their support for that. So this was a first hypothesis. The second hypothesis was conditionality of food supplementation. So we tested if we had a conditional food supplementation that is based on the healthcare seeking behavior, such that patients who are following up with clinic visits, who are following up with medication refills, are the ones who get the food supplementation versus unconditional food supplementation can modify outcomes. And this was kind of around the healthcare behavior hypothesis, where we were trying to assess whether food can be used as an incentive to modify healthcare behavior of patients. So we did this study in post-heart failure hospitalization patients. We enrolled 150 patients. 50 of them were randomized to usual care group, and then 50 to one form of food supplementation, which was tailored medical meals. So these were prepared meals by a third-party vendor. We shipped 14 meals a week to these patients, prepared, frozen, and they can heat it up and eat it. And we tested another kind of food supplementation, which was the third arm of the study, which is fresh produce and pantry stuff that we shipped. And the patients could choose what they want to make out of that. And we gave them recipes, and they were able to cook the food to their liking, not necessarily giving a prescriptive meal. So we wanted to go beyond just testing whether food is good as a treatment strategy to what kind of food supplementation matters in terms of when we are trying to implement it in a post-heart failure hospitalization patients. And our primary outcome was heart failure hospitalization and readmissions in the follow-up for 90-day follow-up period. Our secondary outcome was a hierarchical composite endpoint that included quality of life, heart failure hospitalization, and mortality. And then we also looked at quality of life separately, and we tested the hypothesis for both food supplementation versus no supplementation, and then conditionality versus non-conditional food supplementation. We also focused a lot on acceptability and how patients perceive the food supplementation, and whether how likely they were going to recommend it to their family members and so forth, because we wanted to go beyond just testing the hypothesis, but also focus on implementation, and if we were to scale it up, what would be the best food strategy to move forward with. So in this study we saw that we had relatively fewer readmission and mortality events over the 90-day period. So our primary outcome was null, such that food supplementation did not show a difference in heart failure hospitalization or ED visits compared to no food supplementation group overall, and there was no difference by food supplementation type. But we did see an interesting difference in the hierarchical composite endpoint in favor of the food supplementation group, driven by significant improvements in meaningful quality of life changes of more than 10 KCCQ points. So, which was really heartening for us. And considering the low number of heart hospitalization and ED visits, I think that meaningful improvement in quality of life is a very important endpoint, particularly in this patient population that has high burden of poor quality of life and health status. We also saw that acceptability of fresh produce and pantry stuff was much more than
Hmm.
tailored medical meals. Patient liked the option to cook the kind of food they want to eat, and rather than having a prescriptive meal. So I think that was a really informative finding for us. And we did see that conditional food supply was associated with better hierarchical composite endpoint as well, and better, but the primary endpoint was not different for conditional versus unconditional groups as well, owing to the few number of events as well.
And I just want to make it clear to our audience, the quality of life improvement that you're talking about isn't just like I like the food. It was, I feel better in terms of my
Yeah.
heart failure, right?
Yeah, these are very objective questionnaire-based city cardiomyopathy questionnaire-based assessment of overall health status and quality of life, which is I think actually FDA has endorsed use of quality of life as a strategy for approval of therapies in patients with heart failure. So this is a very robust quality of life assessment using well-validated questionnaires that are assessing disease status related quality of life.
Very impressed with the things you do. Another great study, carefully done, creative, very, very ingenious design, answering an important question. Wow, just keep up the great work. Thanks for doing all that you're doing, and thanks for joining us here live from AHA 2025.
Thanks, Mike.